making the effort to coming in person today to speak to us. Um, You've been extremely generous with your time in kind of sharing your work with our department, and I think it's been great for us to learn about all the work that's being done kind of within the walls of our hospital, especially kind of on this high academic level. So, Greg, take it away. Thank you.
Thank you so much, Ursula, and it's a pleasure to be here. I have a few disclosures in terms of clinical trials, as well as companies or boards, as well as we're all treating people, we should respect the shared land for now and for 7 generations to come. So I love antibiotic resistance discussions and education. I love those in-person environments. We were having a discussion. I think some people just like at home, they love Netflix and being able to watch it, but they'll also come to the movies. And so here's to bringing it back to a more of a movie and a real grand rounds format. Microbiology is a team sport. You can see our UTI health microbiologist. Yan and I are stationed at St. Joseph Health Center, but Larissa's division head covering both sites. You see Randy here, and Dr. Jennifer Tat was one of our trainees who was our locum staff, and now she's moving off to Vancouver, and she really saved our butts from an epic perspective and our clients. And so it is a team sport. You can always call on us. We have 24/7 support, and opportunities like this, as well as work that we're doing in the Emerge at St. Joe's, how it allows us to feel like we're all treating the same patients together. So 3 cases, and we'll talk about the A to P as we go through these cases. Case number 1 is, and I apologize for the text. There's a 57-year-old female of East Asian descent who presented with a chronic infection clinic. That's what occurs on Friday afternoons at St. Joseph Health Center in 1G, where I see up to 4 new consults. To a history of recurrent urinary tract infections, which have increased in prevalence post-menopause. The patient was non-diabetic, non-immune compromised, had no family history of UTIs. She had her UTIs in her mid-20s and would experience 1 UTI every 3 years until she reached menopause, and they're typically associated with intercourse. Following this, she's experiencing a UTI every 1 to 3 months. During an infection, she also had increased frequency of blood in urine. Additionally, she also had a history of ureaplasma, which has been treated with doxycycline. Case number 1 follow-up. At the initial visit, she had finished a 5-day course of nitrofurantoin about 5 days prior for another UTI. She presented with mild cerebral fullness but no tenderness. Urinalysis showed elevated white count, and urine culture showed no growth, though ureaplasma was isolated at our public health lab. From a preventive standpoint, estradiol and probiotics were prescribed. The patient was instructed to administer 1 vaginal tablet 3 times a week to estradiol vaginal mucosa. She was also directed to take probiotics vaginally every Saturday evening to restart her vaginal shield, lactobacillus, which we'll talk about. Antibiotics were also prescribed to be available when she developed symptoms. And we'll also talk about how that pill pocket strategy can work. The patient here consistently used this regimen for 4 months, in addition to maintaining fiber to address constipation. She also took D-mannose, but infrequently and at a reduced dose. She experienced no UTI symptoms, took no antibiotics, and expressed satisfaction with the treatment plan. There were no adverse effects, such as vaginal concerns, back or abdominal pain, rash, or headaches. Are reported. Urine culture at the time showed no growth. After 2 months, the vaginal estradiol tablets were reduced twice a week. So case number 2, different, is a 55-year-old female of Caucasian descent, non-diabetic, immune compromised. She presented with chronic infection complaints of chronic UTIs. This began in her 20s. She was started on semi-prophylactic doses of self-medication for 1 to 2 years until she had anaphylaxis and periorbital swelling. Her treatment then changed to post-coital nitrofurantoin, which significantly improved her UTI frequency. She was later diagnosed with gynecological issues, including cervical cancer and metabolic radiation. About 2 years ago, she started developing UTIs again following a pap test. She would then have off and on symptoms and tried a variety of antibiotics and even a longer course of ciprofloxacin, which yielded improvement but still had some symptoms. She showed to have Klebsiella infection. Unfortunately, began to experience adverse effects of ciprofloxacin, including neurologist and suicidal ideation, which subsided following discontinuation therapy. So I'll get more into the follow-up of this case as we go into the other situations, and focusing on case number 3, which is St. Joe's defining case, and we will end up giving her through this talk phage therapy or bacterial virus therapy. She's a 72-year-old female, non-diabetic, previously well, married, well-educated, unremarkable past medical history. In May of 2016, she had recurrent E. coli infection with ESBL, and that did require ureteral stents for hydronephrosis. She underwent ureteral ligation and reattachment. She received 6 weeks of ertapenem. Total, she received over 16 weeks of carbapenem therapy until we were able to give her phages. And she also went under a right nephrectomy, and she had serious adverse events and reactions, to sulfafosfamycin and treatment level dose of nitrofurantoin. And there was no stone or calculated disease, and she was on vaginal estradiol. So A is for antibiotics, and prior to coming to St. Joseph Health Center, I was the antimicrobial stewardship lead for Prince Edward Island, and at that time, and continue to this day, we have guidelines that focuses on treatment, so you can have an idea. And I encourage us, and I see Kevin here, that we focus on our own treatment guidelines within Ontario, but this is more as a resource, and also Prince Edward Island is very much a community practice with different antibiogram results than perhaps our patients. So you can see how nitrofurantoin, cotrimoxazole, fosfamycin are the leading therapies for cystitis with a straightforward approach of less than 6 days of symptoms. If it's longer than that, then it's more likely that it needs a longer course of therapy, and at the same time, considerations for alternative therapy. So I don't want to spend a great deal focusing on the other aspects of the antibiotics in this situation, but we do intentionally try to save levofloxacin or ciprofloxacin for when we need it, whether it be pyelonephritis or renal conditions that because of the prostates, it's more likely that it's going to reoccur. So for instance, prostatitis occurs in about 10% of first-time episode UTIs in males, and then with the reoccurrence occurs about 50%. And unfortunately, we don't necessarily diagnose prostatitis that sufficiently anymore. We talk about that, it's almost its own talk in itself. So there's also comments on prophylactic antibiotics here in this section, and from my practice, this is done frequently in the family doctor world, but we try to constrict that to those who are undergoing specialist care to assist and modify. So here's a better picture of those guidelines. And then from a pill and pocket perspective, what I'll do for patients is an attempt to maintain macrobid and fosfamycin longer, and with these other preventative strategies, I'll prescribe for both and essentially have them have both options on hand. And so let's just say, start with macrobid, and if there's no improvement overnight, then they'll use fosfamycin. But the intention is to alternate, which is your leading course candidate, to allow both antibiotics a chance to work longer, because typically you gain resistance at 3 to 6 months. I would also say you gain resistance if you don't take care of the vaginal vault, and it's frequently a complaint from patients that says, well, as soon as I stop it, it comes right back. And it's in part because all those germs are right at the vaginal area, right where your urethra is. And as soon as you stop, you clear it in the bladder, it's just going to restart. So we'll talk more about other strategies to help turn that vaginal vault and those who have vaginal disruption or the postmenopausal state back to a shield, rather than a safe haven for bacteria. So embedded UTIs and the need for chronic full dose therapy. You'll hear that more and more. In some parts, it's a little bit of a fascination from a patient perspective, and other parts there's some truth to it, including Nature microbiology studies, where E. coli and Enterococcus form biofilms within the cells, within the bladder, and just like a catheter or whatnot, it requires more lengthy courses of therapy. Sometimes this is overprescribed. I'll talk more about that during the question period. But what I should say is that we should be already optimizing the vaginal microbiota. Ongoing single organisms without other identifiable causes are more likely chronic UTI. We talked about E. coli and Enterococcus, and the courses to choose from they are very prolonged. And so this is something that we would recommend that infectious disease or chronic infection clinics get involved with, because as it stands, these long courses of antibiotics are, let's just say, not necessarily standard of care in Canada, and should be carefully weighed. Okay, so B is for cranberry and B is for bacterial vaginosis. The cranberry evidence isn't that strong, it's somewhat indeterminate, and so we can talk about, there are core co-formulations, it's been heavily marketed. It won't be a central component of today. There are notions that your cranberry should not be in the juice form, it should be in the pill form and have a certain amount of cranberry components to specifically help. B is for bacterial vaginosis, so many of our patients in clinic who are not in the menopausal stage will have bacterial vaginosis transiently or not. Addressing it, taking care of it helps reduce recurrent urinary tract infections. Remember, healthy vaginal area means less urinary tract infections. C is for catheter, so if it's an indwelling catheter, that's not really good, and that's a challenge, especially in our more senior population. And we can go through the ins and outs, no pun intended, of that. At the same time, catheter is a straight catheter to help empty the bladder. What we find is that patients, especially as they approach ages 70, will no longer have the ability to empty their bladder significantly and have post-void residuals of at least 100 mils or more, and that even a catheter at night will help them sleep. This can be done through training, through home care, and some patients are able to do it, some patients are not. There are other tricks to look into this, and then sometimes the catheter frequency has to be increased up to 5 times per day. C is for crystals and calculi. You want to be able to exclude that because they're likely a component where they're coded into the kidney stone or the renal stone. And that requires urological support. It also may require long courses of antibiotics, some suppressive nature, and C is for constipation, which is another thing that is treatable and modifiable and directly linked because of the positioning in the abdomen and how the bladder works when it is not as much room involved. It puts you at greater risk for urinary tract infections. D is for D-mannose. We'll spend a lot of time on this. D is also for double voiding, and it goes back to that idea where, hey, you know what? We still have junk urine that we haven't been able to exclude from our bladder. So the notion on double voiding is to have patients go to the toilets and then either sit there for 5 minutes and kind of do something else. For some people, it's not that difficult. For others, it is challenging, or we instruct them to go up and then come back after 5 minutes and try to urinate again and see how you do. And what's interesting is that patients will start to actually acknowledge that themselves without even having to pose the question. Let's focus on D-mannose. So E. coli has these really sticky arms called pili, and they have a little tip that helps it bind to the bladder epithelium as well as the ureters and other places. And so what D-mannose does, it acts like a smoke screen and binds to those pili at the tip, allowing it to just essentially flush out E. coli because there's nothing left to bind to. It works for 100% of E. coli because it's a mandatory form of attachment, and then it works for 50% of Klebsiella because 50% of them have D-mannose responsive pili. So the dosage is 2 grams daily by pill or 5 grams twice a day by powder through a health food store, and that's usually what I'm recommending in my practice. It can cause bloating, diarrhea, and nausea, and it is instructed to monitor in those who have diabetics, although it's not generally absorbed. More on D-mannose, and here's where we get the lion's share. It'll be about 4 or 5 things, and I'll just essentially give you as much information as I can. I won't necessarily be able to go through all these studies line by line, but suffice it to say that there's a good amount of evidence regarding D-mannose in terms of its efficacy in reducing urinary tract infections in both systematic reviews and randomized controlled trials, and including those more recently, where it was a UTI incidence of 41% in D-mannose versus 50.4 in the control group. This one wasn't statistically significant, and then the study was ended early. It's one of the reasons that we do end up talking about the dosage effects as being part of it. So there is areas where there's no significant difference, and there are areas where there are improvement. And so it's something that's possible and has little harm and can be further studied, especially, as I mentioned, the powder format, which is not necessarily a marketed product. So if you had to walk up to someone and say, what's the most important thing you ever did in changing someone's chronic urinary tract infection life, it would be to add estradiol or estrogen to the vaginal vault. And those who are perimenopausal or those who are menopausal, and especially when you get the story that you may hear in some cases where UTIs once a year and then now UTIs every 3 months, and I'm now 50 or I'm now 55. So thankfully there are multiple options. Vagifem is the trade name for the estradiol pill, and it's provided at 10 micrograms. Did you know there used to be a 25 microgram? It's still Health Canada approved, but they didn't make any money off it, so stop making it. So you can imagine those studies that 25 micrograms is also a consideration twice a week. So in fact, we're statistically underdosing Vagifem consistently at twice a week, which is the standard rate. So in our clinic and in other urinary tract infection teams, they do recommend 3 times a week. If you look at gynecology guidelines and urological guidelines, they actually offer that estradiol, the trade name for the gel or Premarin, can be even more frequently, like 3 times a week. It's just I'm curious why it hasn't happened for Vagifem. Patients like this because there's no mess associated with it, and Premarin isn't the alternative. So if I hear patients say, well, you know what, it didn't work so well, and I was like, well, let's try 3 times. Oh, it's causing symptoms like vaginal itch or just pain or intolerance. And then what I'll attempt to do is just stop everything, right? And then as things come back, then we say, hey, let's try Premarin. It's in part because estradiol is actually produced in soy plants, and that's one of the reasons why Premarin, which is not, is used as an alternative. So as mentioned, I'll do it 3 times a week, and then after 6 months, consider reduction to twice a week. And this is just out of good stewardship because it also potentially reduces the side effect profile. And then if they have their urinary tract infections reoccur, then we just go back to 3 times a week for life. We do monitor for vaginal bleeding, and there are some issues with safety that come up, and it's a big part of the discussion where breast cancer or embolic events. And it's just good to share that as in terms of the amount of estradiol that you're getting, it's about 10 to 14% of what you would typically get in a premenopausal state. And there's a systematic review that really focuses on that you know, if you're in the menopausal state, your estradiol levels are 11. They go to 30 with ultra low dose, and remember that still puts you at the postmenopausal framework of 0 to 30, while premenopausal are 30 to 400. There are other issues or supports of this where the vaginal dryness or other strategies. Remember that there is going to be intercourse in these populations, obviously, and that friction and disruption to the bacterial flora is a potential driver of urinary tract infection. So having extra vaginal tissue and is part of the process of improvement. Further evidence for estrogen and estradiol, and this has like the most evidence of effect. You can see Cochrane review in 2018, RCTs provided by ring or placebo. This was underpowered or retrospective review, showed urinary tract frequency pre and post vaginal estrogen going from 3.9 to 1.8, and that several did not have a urinary tract infection after 1 year following the prescription. So F is for fluid, and for the last 15 years, I've been pushing fluids wherever I could go. This was one long-term care facility where everyone was hearing me talk about symptom-free pee, let it be, and I was part of a national group that helped put these guidelines together. So the reason why it's obviously associated with prevention, there's some actual recent thoughts that maybe fluids don't count as much, especially from a urological standpoint, but I can offer that from my experience, it does. And what's really important is that it leads to people not ordering urine culture for bacteriuria, then getting antibiotics, then getting resistance. So, you know, use it appropriately so it's still available. And so just so you know, the symptom-free P, let it be, and you know, this is in non-pregnant and elderly patients as well, and it stopped treating asymptomatic bacteria. It's not infection. Stop testing foul-smelling dark cloudy urine. I actually get consults, and the only issue we actually get is I have cloudy urine, and so that's something that I think we need to do a little bit more from an education standpoint across the spectrum. And then go to a urinalysis and urine culture of typical signs and symptoms of urinary tract infection to present. We actually made medical directives that gave a dose of fosfomycin at the nursing level in these long-term care facilities when they did have significant symptoms, but that did require a medical directive. There's a toolkit available on the, let's say, Infectious Disease National website, and that's available in multiple languages, as well as with focus on long-term care or not. And so that's a part of the toolkit. So now as we move on to G is for genomics and G is for glycogen. So you're going to have patients potentially coming up to you and saying, well, I got enterococcus because of my next generation sequencing. I sent that to Texas and they went ahead and said that I got enterococcus. I need you to treat it. And I just spent $500 US doing it. So please treat it. So this microgenetics testing has two different levels. The first of which is the PCR report. The second of which is true next generation sequencing. And you can see how there's actually a bunch of things that are covered. You know, microbiologists are around to help and assist in interpreting these results, but at the same time, you can see how it does mention bacterial load is high, and it does mention what percentage is next generation sequencing. Just the biggest thing is to share that samples like this are coming, and we need to figure out what to do with it. And go from there. There are at least 3 or 4 different centers in the United States. There's not currently a center in Canada that's providing this level of testing. And there's also genetic testing available for elements of resistance, but those aren't always necessarily correlated. Remember, when you're talking about really low counts, you can have contamination rather than infection. Is also for glycogen, and this is another thing that we end up talking about. King's balance is a trade name for it. It has both glycogen and a low buffer pH. There's thoughts of giving nitropherotonin post-coitus. I really want to save that for that 2-drug strategy. So although the evidence isn't strong, I'll tell you that we need to have more. I offer that after, and of course, offering the use of the King's balance to help rebalance the healthy lactobacillus is part of my recommendation, so I can save nitropherotonin. And then in patients, for whatever reason, they just don't want to take vaginal estradiol, I will do my best to have the right amount of lactobacillus in the vaginal vault. And that can include up to 3 times a week vaginal probiotics and 3 times a week King's balance on alternate days. So evidence, we need more. In one observational study with not that many people, pre-gel had 4 UTIs a year and 4 months on treatment, 63.5 had no reoccurrence, and just high patient satisfaction. Some of this may be that there's actually bacterial vaginosis, and you went ahead and treated that, and that is a precursor to recurrent urinary tract infections. And there's also just borderline cases as well. H is for Hippurax, and H is for pH. So this is a different tool, not an antibiotic. It is an antiseptic, and it actually makes formaldehyde in your urine. It's Health Canada approved, but you can't get it in Canada. So I have to direct my patients to go to a website, and I'll say it there. Patients get kind of a giggle when I say that website, but suffice to say, we offer that at 1 gram BID. You cannot take it with sulfa because it does interact. There's data to support going up to 3 times a day if there's a catheter. We'd like to try acidification of the urine with a variety of strategies, one of which is vitamin C, which today is not that great. I've shared a few other opportunities. Clinical trials are underway, and there's the website, and they do ship. More on it, the evidence is still coming, but you can see how that in some areas where they just did RCTs with that drug versus trimethoprim, there's the same rate of recurrence of both groups. And retrospective studies for UTIs for those greater than 60, average time to UTI pre and post for the methylamine hip rate was 3.3 versus 5.5, and significant amount to not have UTIs after initiation. There's review articles available in terms of 73% reduction, but remember these are earlier studies like 1987 or 1974. And then Cochrane review of 13 studies showed short-term measurement has significant decrease in symptomatic UTI. So this is an antiseptic, and so tricky organisms, in particular for Pseudomonas, where you're trying to work through that and you have very limited options for chronic suppression or other strategies, that'll be one of them. Also further, I use this in situations where I can't get rid of the extra urine in the bladder because of the catheterization isn't going that well. This will be another strategy. It is usually end of the line strategy though, before we talk about another letter. Eyes for immunization, eyes for installation. So there is a vaccine. It has been tested in Canada. It was recently taken off the trial list from a Health Canada perspective, like as in part of their application because of a minor issue, and they're looking to reapply, but that restarts a 2-year clock. It's likely to be available in the United States within the next year. And I do have patients who go to the UK or Tijuana or other places in order to get it. What's interesting about it from an immune system perspective, it moves the immune system from a Th2 response to a Th1 response, and maybe perhaps with that idea of targeting intracellular biofilms, and it targets 3 different or common organisms cause urinary tract infections. A J is jump on a plane, I kind of mentioned already, by going to the UK, and there are places in the UK that just focuses on chronic urinary tract infections. They actually don't use urine culture as a strategy, or if they do, they have like this 48-hour or longer culture just to find everything. So that's a little bit, let's say, off the beaten path. We have 2 clinics in Toronto, 3 if you include also Dr. Tony Manzuli's services. In Georgia and Europe, places are going for treatment, including the use of phages. And in Louisiana, there's a famous Dr. Bundrick who likes to give long courses of amoxicillin hyaluronic acid, and we're talking 6 months or longer. And he'll also offer trigonal fulguration, where they'll go in and under anesthesia, blast away an area right at the opening of the urethra from the bladder side. So K's keep looking for answers. So there's 2 Facebook groups, and it's actually really challenging because if you dip into the Facebook group world, it gets really messy quickly. I can say that I'm a moderator for 21,000 international Facebook groups addressing chronic urinary tract infections. I try to be very mindful that I'm just giving general medical education and not medical advice. And at the same time, it's there to promote discussion. And I learn from them just as much as they may learn from me from time to time. There's also one that I started, it's called Take Off UTIs, Healthy Urinary Tracts in Canada, with about 50 members. There's a website called Live UTI Free. They're the ones that are telling us that all our urine culture testing isn't really accurate or satisfactory, and there's multiple other perspectives on that website, but that is one that patients tend to go to. We're almost getting to P. L is for lactobacillus, and oral systematic review. So that's just focusing on just standard probiotics show that the reduced chance of diarrhea, you never need to treat 11, and C. difficile risk reduction and is also significant. From a vaginal perspective, there's usually 2 things that I offer in the toolkit. One is Prova Care, which has a milk base to it, and Provac Black, which has a soy base. And you can often hear that there's significantly less urinary tract infections when patients replace on probiotics. And with microbiome changes with less vaginal E. coli, proteus, and more lactobacillus. And there's also placebo-controlled RCTs with significant reduction. So we actually, in the lab, will look for the amount of lactobacillus present in the vaginal vaults. And my biggest goal as a microbiologist going on the offensive is have that area protected, reducing the chance of any urinary tract infection, as well as any sort of biofilm that may be present in the vaginal vault. So that's where lactobacillus comes through. And as for mycoplasma and mycobacteria, mycobacteria is straightforward. Steropyria, those may have risk factors. Mycobacterium tuberculosis can cause any disease, including general urinary disease. And as for mycoplasma, that is an organism that doesn't have a cell wall, and it has its cousin called ureaplasma. It is associated with somewhat controversial with urinary tract infections. There's like a standard colonization rate of people with maybe 30% or more for this. And there's like different types of mycoplasma, one of which is mycoplasma genitalium, which is more associated with a sexually transmitted illness and has more drug resistance. It's also harder to identify. So suffice to say, there is a laboratory within nearby in Vaughan that will do testing on a rapid basis for this. At the same time, we do culture at Public Health Ontario, and I really want to pay attention that on the reports, they actually say mycoplasma genitalium is not identified through this method. And it's super frustrating because your patient may have mycoplasma genitalium. So if you press them on it, then they'll send it to the National Microbiology Lab to actually do the testing that every other province has access to. Or you have to ask like Life Labs to do mycoplasma genitalium testing, which is available for a cost of approximately $90. So suffice to say, mycoplasma is part of the thing. So if you are seeing issues with their pH being too elevated, which more suggests their urea splitter of urea plasma, or there's still pyuria or symptoms like why is there a lot of inflammation in the first part of the urine that we continue to see, then mycoplasma can be a consideration. And as for naturopath, there's garlic and there's oregano and there's so many other options. Dr. Ashley Gerard is a naturopathic physician that's nearby, and some patients get referred to me. Sometimes I refer to them when they're interested in that. And I'll leave it at that for now, but it could be its own talk in and of itself. As for obesity or operation, obesity is directly linked to increased urinary tract infections in terms of a variety of issues. I appreciate there's also confounders. O's for operation, either having had operations or potentially as a consideration for doing a procedure or operation. P is for Ceridium, and that's actually difficult to get here in Canada. Very easy to get. It's called AZO in the States. You can get it from compounding pharmacies, and it is really just something in those who have overactive bladder or other strategies to take that burning sensation away. I've actually been involved in cases where patients, one was a physician who said, well, I did it, and then they ended up getting pyelonephritis because they didn't have the detection of the cystitis anymore until it was too late. That was also in a transplant patient too, and so I wasn't involved with their pre-care, but it was very interesting how by masking symptoms, you also put yourself at greater risk. And P is for phage. Yay, phage. So I'm going to stop for a second to take any questions before I then go into the phage world of things. Is that okay? Okay, well, I'm not seeing any questions so far, so now we can go into what I'm super excited about. I am St. Joe's first name professor in something from the University of Toronto, and that is in bacteriophage therapy research and innovation. So it is a team effort, including Kevin and others in this room. I sharpened my teeth doing phage on outer membrane receptors when I did my PhD at Arizona State before going to medical school at the University of Ottawa. And this was actually just recently published, where you can see what's a phage. A phage is a bacterial virus. It doesn't target humans. It then goes ahead and injects its DNA into the cell, and then the cell no longer, it's the bacterial cell, no longer makes bacteria, it makes phages. And you can see the little heads coming out and bursting out. So the notion is they have a standardized genome. The notion is they go ahead and produce, guess how many dots you see? So at the site of infection, you'll make 30 to 300 of the drug that you need to target the bacteria you want. So in addition, that this is a very specific, down to the level of like E. coli, and then you may need upwards of 30 to 400 different types of phages to target E. coli. It's nicer for Staph aureus, where you may only need 5 phages to target that broader group, but it's not like an antibiotic where it's causing a lot of collateral damage. So let's ask a question. I think we have 4 or 5 in the room here. As of November 2022 in the published literature, how many patients have been treated with phage therapy for a urinary tract infection? So raise your hand if you think it's been 5, 200, 800, 1,000, 1,400. Sure. Okay, so we have a good spread of that, starting at around 800, and it's actually over 1,450 have been treated in the literature. And when you look at sites like Up to Date, they would say phage therapy is like, hasn't been used, not a lot of cases. I'm just talking about one condition or syndrome, and you can see how that is part of it. So that was in a published systematic review, and you know, this is me on my soapbox, so forgive me for that, but phages outproduce and out-evolve bacteria. We do not have the lives and dollars to spare to keep this targeted and personalized medicine on the sidelines in Western medicine. When we look back since the 1920s, and it's shown that around 1,400 UTI patients, phages occurred between 50 to 80% and only 1% minor side effects. And we actually even did further work on this, and there was the systematic review that we published, which you know, as mentioned, there was a potentially around 80% case of improvement. We did a subgroup analysis on that, and all this data is available in supplementary information, which shows that in the 507 cases for phage alone, and was mostly gram negatives, mostly given intravesicularly. There was a cure between 74 to 98%, and there was no improvement identified for 4 cases. Eradication was as high as 80%, and there was only 1 minor adverse event. So remember, phages predate antibiotics. So our first clinical trial for UTI and the second phage trial in all of Canada was done at St. Joseph Health Centre. You can see Jitin from pharmacy, our patient Victoria Marshall. She's now a patient advocate. And these were the stars as well, the 3 phages that came from the Baylor College of Medicine Taylor Labs, where they tailor therapy for personalized phages. And here you can see with the different phages, the different levels of infection in the test tube that they work synergistically for the different ways. HP3 is like an evolution of HP 3.1 if you pass phages enough, or you can actually modify it so it actually works differently with a broader host range or other characteristics. This took so much effort, and Carlos, shout goes out to him, as well as Peyton Hui, who's now I think 2nd year at University of Alberta Medical School, or faculty of medicine. You can just see just getting to the step of signing an RB, because there's no way to get this medication otherwise. It's a research medication. It took over 155 people contact time and at least 25 steps.
New parking garage, P1 elevator lobby. Code white, new parking garage, P1 elevator lobby.
And you know what? I missed a step. So after I finished the trial, I said, hey, you do not call Climate Change Canada and tell them that you're bringing this new organism into the country. And I apologize. So there's even further steps involved once you sign the process and on the dotted line in order to get things across the country. And it costs as much as $5,000 just to have it go from one side of the border to the other. So there's a lot of challenges to getting this done, both from logistics as well as from a costing standpoint. It had a very positive outcome. In short, we gave bacteriophage therapy topically, and that's at the vaginal opening, orally just once, and bladder and still just once. And this is Dr. Imogen Jane. You can see us in clinic, and then also with our colleague in Houston. The patient did require antibiotics at day 14, and there was a mild reoccurrence at the same time, as well as some symptoms of diverticulitis, which was unusual. We treated her just a simple course of ertapenem without extra phages, and now she's had a prolonged cure from this E. coli, and it's a positive story. So case 1 follow-up, just wanted to highlight the urea plasma urolithin that was found was isolated. The pH of the urine was elevated. There's only trace leukocytes. And there's also a partner involved. And so suffice to say, we didn't treat the urea plasma. We start running out of antibiotics. Doxycycline may work 50% of the time. Levofloxacin may work 90%. And then the teachable points for that one is vaginal estrogen use consistently, not only during UTI and probiotics may limit or decrease the frequency of UTIs. Denounce the lack of effect reducing UTIs when taken at reduced dose. And considerations when determining if treatment is indicated for urea plasma or not. From a case 2 follow-up perspective, and this was a 54-year-old female. She was on a variety of antibiotics and not feeling well with a long course of cefixime. She was then transitioned to other antibiotics and saw a significant improvement after a prolonged course. And this is, the notion of targeting biofilms. We did increase her Premarin as well as use probiotics and ultimately use Ciprex. And then after 4 months, later, now I think it's been 8 months, she's been UTI free and she feels like she has her life back and starting new relationships and stuff like that. So the teachable points is that Vagifem and later conjugated estrogen creams, we had to switch to Premarin to estrogenize the vaginal area. Successful use of vaginal probiotics, as well as a variety of other strategies, and demonstrates how post-coital measurement can work in synergy with non-antibiotic preventive measures in chronic UTIs. She's one that still gets that. So for case number 3, I already kind of told you some of the issues that happened for the phage therapy. There was a slight rash at days 7 to 10, and the latter one was mildly pruritic. We had a safety committee review these findings. I mentioned the diverticulitis. And then, as also further mentioned, she's now had a clinical cure. We're trying to figure out what was the deal. So when we did a CT scan at the time of the diverticulitis consideration, we could actually see the blind ureter. Remember, this was connected to her kidney previously and then cut. And you can actually see on how it's a fairly large bladder as a whole, as well as potential for a significant amount of biofilm. And that was one of the reasons why she may have had reoccurrence consistently. You can take a look here for her video. She made CTV national news, and there was a notion that we were going to have a new urinary tract infection clinic. I presented this in several situations, and as well as in peer reviewed processes. We're looking to publish soon, and I'll talk to you a little bit more about global clinical phage rounds. I'm the privilege of being the international chair for global clinical phage rounds, which is a group of 390 mostly clinicians that talk about phage therapy cases. And you can sign up today if you'd like to be part of it. We have actually, out of the 390, 120 of them are Canadian. So we kind of flooded the space, and I encourage further flooding. We're looking to move to a randomized controlled trial stationed at St. Joe's, and we've received some funding from CHR, it's called bridge funding, from a previous application. And in short, we'd be utilizing phage therapy in a control group, which would have placebo, but as well as in the phage therapy arm, we would have the same sort of treatment that we provided before with oral therapy, bladder installation, IV ergotamine or ceftriaxone 1 dose, as well as topical therapy. And then we have a primary outcome after 30 days to show that the E. coli that was found is gone. We're also looking to make this as part of a European trial called the Horizon Europe trial process. So you're starting to get the idea. I do a lot of phage stuff, and so besides the systematic reviews and seeing patients and working in trials, I was the co-founder of Phage Canada. So if you're super interested in phages, please become a member. We also have public members who are members of Phage Canada. We're also like, what can we do in a clinical microbiology lab? So we need to work on biobanking. And you see this as a situation where I was monitoring discussions on that, as well as develop a toolkit or a box to help us rapidly find and personalize phages so that we can use them. Just like we do testing on our Vitec machines or other machines, we would need to build the machines that are moving forward. I'm also part of an expert panel looking to define what phage susceptibility is. So with that, here's more information on Phage Canada. We now have a board of 7 members from across the country, and that's exciting. There's an FAQ, so if you're more interested in phage or you have patients who are interested, there's an FAQ from our website. And at the first center in North America is the IPATH Center in San Diego, and Dr. Stephanie Strafferty actually was an epidemiologist and now lives less than 10 minutes away from us for her vacation home. But when she's in San Diego, she's working at IPATH, and it's a fascinating story and book about how she helped launch the modern age of phage therapy, at least in the North American context. So how to refer to me through Epic, through OceanMD, and we now have a new clinic called You've Got This, and it's in the idea that you got this organism as well as you got this empowerment. So empowering you to gain agency over your health. This is at 2200 Rutherford, and it's a private clinic where we're focusing on urinary tract infections. I usually see new consults at the St. Joe's Clinic or complicated ones at the St. Joe's Clinic, but then I use this clinic as well. Otherwise, I get so many emails or texts or other things, and I'm really trying to modulate my practice into a sensible rhythm. So if you have questions, please let me know. There's also an evaluation code, And you can see here, I'm in my St. Joe's office and go for phage. So you can appreciate that this is both precision as well as passion. That's going to help us target infections. And as it relates to urinary tract infections, there's so much we can do from a preventative standpoint. Here's our St. Joe's student crew, and Josephine in particular is right here. And she's a University of Ottawa second-year student who is instrumental in having this talk together. She submitted an abstract to talk about not only these two cases that I presented initially, 1 and 2, but cases 3 and 4. And then ultimately, I want you to have this discussion at the dinner table. This was a telemetry discussion on antimicrobial resistance. And this is Andre Picard, a well-known journalist. And I was saying, hey, we have to be talking about this at the dinner table. We'll talk about other things. So I don't want to talk about the dinner table. It's like, well, I'm going to help start that because this is super neat and super important and life-saving. When we have antibiotics that take $2 billion and take 10 years to invent, phage therapy and other tools from a preventive standpoint is exactly what we need to explore and study. Thank you for your attention. I'm happy to take questions.
Greg, thank you again for an excellent talk. There is a question in the chat. I don't think it's been addressed yet. It's from Ajay. I thought Peridium was removed from the market due to methemoglobinemia risk.
It is not markedly available or readily available. It is available through compounding, and it's available in other countries. So you're right, there are some challenges with that. We put that in perspective. Of all the arms, I have actually never personally prescribed for that or asked some patients to do it. It's been something that they've already been doing, and I try to move them away from that. So it's not a key tool. Thanks for the question.
Thank you. I just have a comment and a question. I'm really very pleased to see all your efforts in this rather complex and difficult to deal with problem. And I just wonder whether I need to have a little more emphasis in prevention vis-a-vis making sure that the urethra stays clean and not getting contaminated. And avoiding prolonged exposure to catheterizations as much as possible. And I like your comments on this.
I appreciate that. And we go through that. I think the patients always say, well, yes, I'm always wiping the correct way. And we work through that. So I don't have those references ready hand, but I'm happy to review those. You know, in this world of empowerment, many patients have already gone through the education of what to do from that perspective. I didn't focus much of the talk on catheterization or challenges associated with that. And you know, intellectually, we try to really push for catheterization only 3 to 4 instances, and for a short-term basis. If I could talk more about catheterization, is that after about 14 days, all urine catheters are permanently colonized. I've had to utilize some strategies in this population, and some of them are off the beaten path. One of which is a little bit more clear is to change the catheter every 14 days if you do have a chronic catheter. The Hippocrates has more evidence around utilizing that in their chronic catheter standpoint. And then in certain situations where there's another patient that we're thinking about providing phage therapy, he actually self-catheters with fully overnight. So he gets his chance to sleep well, and each new day he has a new catheter. So rather than doing 5 straight catheters, he'll have from a harm reduction model. Sorry about that. From a harm reduction model, he'll catheterize like that. We've had to do that in another case I was consulted on in a different province, where otherwise it was very difficult. So try to limit the amount of catheterization as much as possible. Consider reducing the frequency, increasing the frequency of changes to every 14 days, and then consider other alternatives than chronic catheterization, because that is essentially from a microbiological world a dead end. There's a lot of strategies in terms of making sure that the backwater for the catheter doesn't go back into. And I would also say that I don't think chronic antibiotics work in catheter care because there's such a high capability of developing nitrofurantoin or fosfomycin resistance in that puddle of urine that's left, and those bugs are moving. So that's one of the reasons why Hipprex as an antiseptic could be consideration. If you please feel free to email me if you'd like to have further information or references, and I can add that to a future talk. That's a good question.
Greg, maybe I'll ask a quick question. How about we sometimes see this in oncology, women who have had breast cancer who are on anti-hormone therapy and who have recurrent urinary tract infections. And there's kind of this kind of controversy around, or at least some degree of concern around offering a topical estrogen therapy. And I guess like for patients like this, do you have a particular approach or preference in terms of what to do?
Work with a medical oncologist. Next question.
Okay.
Yeah,
We usually refer to gynecology, so I feel like we do ask for other
Yeah.
expert advice.
It's a great question, and there's actually Winters, a urologist in States and famous on a social media website, that she essentially says that in every patient, every time you can give estrogen. There are some issues with receptor positive breast cancers, and that there may be an increased risk. I think we have to put that in the perspective of everything else, what the gain is and their quality of life and suffering. It also is one of the reasons why we're trying to push, if for lack of a better word, non-estrogen based methods to see if that would work, including like the glycogen formulation, the Keynes balance alternating with the probiotics. So it's also a further reason, we're going to try the lowest dose possible. So as I mentioned, 3 times a week for 6 months and then reduce it. For them, it may only be once a week. So, the biggest issue is trying to balance through a variety of strategies. If it's multiple recurrent breast cancer, obviously that's an important thing. Your gynecology can also talk about it. And then there's also a notion, even the pessary nowadays have estrogen coatings potential as an option in those in our senior population. I know that's a little bit different than your question, but suffice to say that we do have to address the major issue, which is not enough lactobacillus, and there are multiple ways that we're trying to work on that.
Thank you very much. There's another question from Ajay, actually. It's very common to have patient families say urine cloudy or smelly and insist it's infected in your urine culture. Any thoughts on how to handle?
Yeah, so send it to me. Symptom-free P let it be would be that campaign and there's actually a letter that in the residence halls, or sorry, the long-term care facilities, that the staff would write the patient and say, hey, 50% of the time or more, this is not a urinary tract infection. We do monitor closely for symptoms. It takes 7 minutes to say no to an antibiotic. It's the same idea, but it's an important 7 minutes to have when you're saying, not right now from a urinary tract perspective, hydrate first. The hydration can be as short as 4 to 6 hours. Getting fluids in someone who doesn't want fluids is very difficult. That's a little bit of a talk in and of itself. But the most straightforward thing I would do is, hey, let's focus on what we really want. And that's not drug-resistant infections. That's not coming to the hospital and having to need IV therapy or not having any choices. Let's talk about what we really want, and that's better, health and wellness. And so every hour on the hour while they're awake, we'll request that they try to drink their preferred fluid, warm, hot, with lemon, with drops of something, as a way to increase their hydration. I will ask them to point at the wall, which is kind of a very light beige yellow, and it's like that's the color of the urine that we're looking for. And the family members start to get it. So I personally, this is a touching moment for me. Like, my mother died in a night of intensive care because of a drug-resistant urinary tract infection, and she had a long-term catheter in place and was from a long-term care facility. I actually wrote about it in a Plains piece in October of not this last year, but the year before, and on how this is part of my mission and why we're trying to address urinary tract infections. And so, if necessary, I'll actually share that personal antidote to say, let's focus on using the right antibiotics at the right time and really make sure that we increase monitoring as well as fluids. I really appreciate all the extra questions, and I think, if you'd ever like to reach out to me, you know how to get a hold of me. It's a pleasure to be here at Centos.